All right, so they haven't joined yet. The time 5 past. I might just get started because there's, a fair amount to get through, and I want you to have time to ask questions at the end. And as I mentioned last time, I will be sending these slides. I'm going to have to break them down into, because they're so large, I'll break them down into smaller units, and I'll take out the videos which I'll be showing, but all the content will be available, and I'll email that to you guys. So before I get on to treatment, I just wanted to start with this. This was some information that was co-designed by people who live with FND. It was done at some workshops that we ran in 2019. And there are a lot of, there are a lot of myths, there's a lot of confusion about FND because, you can't see it on a medical scan. There's a lot of stigma, and, health professionals, the community don't really understand people with FND. So these were some points that people came up with around addressing some of the myths around FND, and how they would like people to respond to them, or what they wanted people to know about FND. Okay, Ange and Ali entering. That was good timing. Awesome. Hi, Ange and Ali. They were just starting. So what people want others to know is that the symptoms are outside their control, so they can't just turn them on and off at will. And what people needed was for bystanders to remain calm and patient around them. They wanted people to understand the illness in a way that respects their feelings and opinions, because FND can arise from many different reasons, which may be trauma, it might not be trauma, it might be physical health, it could be anything. So they want the illness to be understood in a way that they related to. The next point was around disability aids. So some people require disability aids, some people don't. Some people need them at certain times, but not other times. And they wanted to be able to use the disability aids that they needed when they needed, and not have thoughts, oh, you're going to become dependent on them, you're weak, you're not trying hard enough. It's around using the right equipment at the right time. And the thoughts that they're going to become dependent on them are not necessarily so true. It's using them in the right manner, in the way that it's designed. The big one is my symptoms fluctuate across the day and on different days, and I can have different physical abilities and symptoms in a very short space of time. And that's the big one, especially with stigma and discrimination. So, you can see someone one day and they're running around the oval, and the next day they might be wheelchair bound. And that's very much the nature of the illness, is with that stress response, the nervous system's not functioning properly, so it might completely shut down. The person might be paralyzed, their gait might get completely out, and yet a short time later they might be walking or running. And we had one little girl at school, and their school was really, really supportive. And, the mum said to me, I dropped my daughter off at school. She walked into the classroom and got on with her day. During the day, she lost the ability to walk. So there was a wheelchair kept at the office. Someone came down with a wheelchair. She then spent a few hours in the wheelchair. And by the end of the day, her symptoms started to dissipate, and she was able to walk back home. So it's around having the equipment that they need at that time. And then, the symptoms might improve if they're one of the ones that do fluctuate, and then she didn't need it later on. People wanted to feel heard. They're saying, please listen to me, please ask, don't assume. And this one related more to treatment is, some people have had a lot of trouble getting treatment, and there's thoughts around, some people are sent away with absolutely no treatment, and they don't just recover. They might say, I'll go home and, just get rid of your stress, or just have a good night's sleep and you'll be fine. That is not necessarily the case. So people don't necessarily just recover on their own. But for some people, even with the best access to, a multidisciplinary team, they might still not recover. So people do need the access to treatment, but even with treatment, some people don't improve, and there are people that will have ongoing symptoms that, for that particular moment in time, they're just not improving. People wanted to know that they're more than the FND. A lot of people are just sort of written off. We've had adults that had, flourishing careers, they had families, were living a really good life. And then all of a sudden, all their dreams and hopes and friendships and families are all sort of dashed because all of a sudden this illness has come in and they're stuck at home in bed and unable to move. So, sort of I am more than my FND. I am a person with dreams and ambitions. And especially for students, they've got, and we have a lot of students saying, I had dreams of doing A, B, and C when I left school. And then all of a sudden, what does my future hold for me? And that can be really scary, especially for a person in that sort of vulnerable transition stage, like year 10 and onward, sort of thinking about what am I going to do with my life? And all of a sudden this FND has just come on board and I don't know what my future holds for me. The difficult one that people have been accused of is attention seeking. And people are not attention seeking. They're not turning up to emergency for the fun of it. They're actually just seeking help to deal with symptoms that are really distressing and frightening for them. If I could control my symptoms, I would. So the symptoms are completely involuntary and they're out of the person's control. And people can't just think themselves well. Obviously, positive thinking and all that sort of stuff is helpful, but it's not enough. So people do need access to multidisciplinary treatment, and that treatment needs to be tailored to their specific needs because FND is very complex. It's multiple different types of symptoms. So the treatment needs to be tailored to the individual. Information is important. A lot of people are sent away. If they're lucky, they might get a label. But they're not sent away with any treatment, and people are really confused. Families are really confused. In their state, they don't understand what this condition is, and they've got a child dealing with these horrendously disabling symptoms. So having information on hand is really important for people. People are more than their symptoms, and it's important for people to do activities that they value, and that's important for their recovery and their well-being. And from a sort of social inclusion point of view, school is a really important activity for some people. You've got your learning, your future career, but also your friendships. So it is really important to, where possible, trying to include students in the school environment. We do have some students that will do school from home, online learning, but having that sort of normal social interaction, even going to school for shorter parts of the day, not a whole day, is really important for their overall well-being. And this one is around, if people are having a seizure and they're on the ground, they can't respond. So you could be talking to them and they might not be able to respond to you, but they can hear what's going on around them. And a lot of people describe sort of feeling trapped in their body, like they're aware of what's going on. People are asking them questions. They want to respond, but they're completely unable to verbalize their response. But they can hear what's being said. And a number of people have heard some really distressing things that have been said around them. A nurse said something like, oh, you're attention seeking, or you're a drama queen, or you're the world's best actor or something, and the poor person's having a seizure. People are doing the best they can, and people saying, if I could push myself harder, I would. And what we generally find is the people with FND are the ones who do actually push themselves really hard, and that's generally how they've ended up with FND, because they have pushed their body basically beyond their limits. And people are the best judge of what their body can and cannot do. So if people push themselves too hard, like if they potentially come back and try and do full-time school straight away, they could have a relapse. So that sort of graded exposure kind of stuff is really important, not sort of making someone do a whole lot of work and then they will just collapse. And that can be quite important around exam time when people are under stress anyway, and trying to do 3 exams a day or this sort of stuff. It can be too much for the person and can lead to quite a severe relapse. So just in terms of treatment, I know you're not specifically going to be doing treatment with people, but just to sort of cover a bit of that, multidisciplinary teams is sort of the ideal model of care. everyone sort of needs to acknowledge, and everyone needs to be on the same sort of giving the same information. So acknowledging that FND is a real disabling person that causes neurological symptoms, and that the symptoms are outside of the person's control. The symptoms of FND, they like to say they're potentially reversible. So potentially reversible means that we don't have spinal cord damage, we don't have physical structural brain damage. So because we don't have that, you know, structural damage that you might have, say, in a spinal cord injury, there is a potential that the nervous system can be effectively rewired. And so we've got this miscommunication between the brain and the body, but it's possible with rehabilitation that the person can rewire their brain and use different brain pathways to improve their symptoms. In terms of diagnosis, there are positive signs that are used clinically to diagnose a condition. So it's not necessarily a diagnosis of exclusion. And FND can coexist alongside other neurological conditions. So, you know, if a person already has autism, Parkinson's, MS, epilepsy, very common epilepsy, cerebral palsy, FND can be quite common to be present alongside other neurological conditions. Triggering events can, you know, exacerbate and cause episodes of FND. So what we really want to do in terms of self-management is helping people understand what might trigger an episode of FND. So for a lot of people, that might be stress, it might be getting too tired, it might be doing too much while you've got a cold or you've got flu. It could be any environmental, social kind of interactions. You know, I know there was one person that there was a teacher at school that was very triggering for her. And that used to always send her into an episode if she had to talk to that teacher. So when we understand what's potentially triggering an episode, we can start to do something about it. And what's used as part of treatment is this thing around, if we focus on our symptoms, they get worse. But if we distract our attention away from the symptoms can temporarily be reduced. And that can be things like if you've got a tremor, if you deliberately do something else, then the tremor symptom might improve. The body's stress response is very much involved in the functioning of the nervous system and then the body's FND symptoms. So trying to manage the body's stress response is really important. And that's trying to, you know, down-regulate the person's stress response, help the person stay calm, help them stay grounded, because that stress response will exacerbate symptoms. And any other underlying health condition will exacerbate FND symptoms. So if you can get other health conditions under control, we often find the FND symptoms may be reduced, and things like comorbid eating disorders will obviously make the symptoms worse. If people have vitamin deficiencies, we had one girl that was having problems, sleep apnea, so she wasn't sleeping and breathing properly. So when that got under control, her FND symptoms were dramatically reduced. So addressing any other underlying conditions can help your FND symptoms. And we've had other people that it was triggered by a certain medication, they came off that medication and then their FND symptoms went away. So there can be coexisting factors that are contributing to this. So in the ideal world, the person would have a multidisciplinary team. The condition should be diagnosed by a neurologist, and the neurologist should stay involved to have ongoing testing, ongoing monitoring, and ongoing management and review, so that if the person gets a new symptom, the neurologist can investigate, they can check for any other underlying medical conditions or any other underlying neurological conditions, and they just stay involved in the person's care. If the person has motor problems, so they've got problems walking, they've got problems with paralysis, they've got problems with dystonia, they should be under the care of a physiotherapist. So the physiotherapist will provide education about FND, support self-management strategies, support gait retraining, posture. and relearn normal movement patterns, because what often happens in FND is you lose those automatic movement patterns. So things like, people without FND can walk without having to think about each movement. A person with FND, they've lost those automatic movement patterns and they have to relearn how to engage in basic movement patterns. An occupational therapist is often very important as part of self-management, as part of education, addressing daily living activities. So when people are quite disabled, even going to the toilet, having a shower can be extremely difficult for someone with FND. If they're quite disabled, they can look at activity prescription. So what activities might be therapeutic for them in terms of skill building. They can look at relaxation strategies, task adaptation. So grading tasks, adapting tasks so that they can do it. If they've got dystonia in one hand, they can't use one hand, helping the person to relearn how to do that task until their hand improves. The hand function is obviously quite relevant in the school environment. If people can't write, they can't type. We have had a lot of people with hand issues trying to manage school with FND. And the other thing that occupation therapists do are equipment prescription, but also really important for the ongoing review and education around equipment, so that the equipment is meeting that person's needs in that moment in time and they're not overprescribed or underprescribed equipment. A speech therapist is relevant when a person has swallowing problems or when they have speech disorders. So some people will lose the ability to talk and other people lose the ability to swallow. We have some people who have peg tube nasal gastric feeding because they completely lose the ability to swallow. A psychologist or counsellor is really helpful, even if the person doesn't have underlying trauma, if they don't have coexisting mental illness. Just living with a condition like this and living with adapting to a disabling condition, counselling is really important. Psychotherapy, mindfulness, and learning, strategies to help ground the nervous system and cope with this condition. So we want to look holistically at the whole person. So the body, the mind, looking at the environment, looking at the social environment. That can be a trigger for some people. Interpersonal interactions can be a major trigger, either within the family, within the school environment, on social media, etc. And also the physical environment. How is the person managing with their disability? Are they going to need major disability modifications? Are there sort of disability barriers that they're dealing with? It's important that the person has, and the family as well, have confidence in the diagnosis. So if they're searching for another answer, which does happen, a lot of people will say, oh, I don't have this, this is in the DSM, I don't have a mental illness. So if they're searching for a different answer, they're not going to be engaged in treatment in terms of addressing this condition. So helping to explain the diagnosis is really important, and that the person understands the diagnosis. The treatment for FND is quite different to other neurological conditions. So even if another neurological condition, for example, stroke or epilepsy, presents exactly the same way, so physically it looks the same, if it's FND, the treatment is different. If it's a stroke, you might be focused on, I have this weak limb and I need to move this weak limb. In FND, you want to focus your attention away from the weak limb and focus on something else, and then the weak limb starts to come back on board. As part of managing FND, we want to identify vulnerabilities, triggers, and perpetuating factors. So we had one child that had she was raped at school, and attending school was obviously a major trigger and perpetuating factor for her. So she had to come out of that school environment because that was keeping her in the symptoms. Addressing and trying to prevent secondary medical trauma and the feeling of not being believed, not having their symptoms being regarded as real, that adds a whole nother layer of trauma onto people's experience of FND. Trying to manage fatigue. Chronic fatigue and chronic pain are very common comorbid conditions with FND, and looking at the ongoing social, interpersonal and environmental stresses is really important because they can be contributing to the FND. So in terms of the physical therapies are designed to improve the pattern of movement. The strategies are designed to redirect attention away from the body to reduce the motor symptoms and to normalize movement. So that's in contrast to how it might be for, say, stroke or other conditions. And looking at the impact of attention. So if you use videos and feeding back to the person, I've got a few videos to show you in coming up, is around, this is what your movement looks like when you're focused on your limbs or your body. And when we distract from you, this is what your symptoms look like. So with treatment can be regarded as a form of brain training. So trying to reorganize the brain's neural pathways and trying to redirect people's attention. So getting away from this abnormal pattern of movement that are driven by this sort of self-focused attention. When you distract the person's attention away from their body, the symptoms can improve. And some people will use this as, oh, I saw you doing this yesterday, so you're obviously fine. And when the person's busy, their symptoms are not there. So they think, oh, you must be putting this on. But it's actually a neurological thing in the brain that they can actually see when they do the brain scans, is that if we focus the person's attention away from the body and they get distracted and doing something else, it sort of sets up a different neural pathway in the brain. The neuroplasticity, what we're trying to do is, reorganize your sort of sensory, communication within the brain. And for children, they will have a greater level of neuroplasticity. And this is why we tend to see better outcomes with children when they get the right treatment. So you might be playing mind games with the children, that sort of cognitive games that, solitaire or anything where they've got to be focused on doing something sort of fast, which distracts their attention away from what's going on in their body. Body-based physical activity. So I've got some examples of that. So that might be, instead of just focusing on putting one step in front of the other, you'd be doing another activity. So you might be doing your times tables at the same time that you're doing a physical activity. And also providing sensory input. So some people say, if we put some ice on your leg while you're having a seizure, that might help to bring you out because you've got that sensation. It's around finding the right sensory input for that person. But again, that can help to reorganize the sort of the way the brain responds. So this is just really around, the physiotherapy. So a physiotherapist would explain FND, would explain what the condition is, that the symptoms are potentially reversible as the nervous system is not damaged. You demonstrate that normal movement can occur. So when we distract you, your body can actually do these normal movements. So it's around how can we encourage the normal movements to occur and sort of dissipate the abnormal movements. So they'll teach and practice normal movements, reduce the self-focus, so take your attention away from the movements, providing feedback to the person through videos, through the use of mirrors, building up complexity of movements. And the other thing is, even if people are not improving through physiotherapy, the ongoing physical treatment is really important, because people will otherwise, they'll get deconditioned, they'll get functional decline, they'll get all the secondary changes that, they would if they were sort of just sitting in a wheelchair. So even if the person is not able to, get back to full physical function as they were prior to the illness, ongoing physical treatment is really important, because otherwise they'll just get all your secondary decline. So treatment needs to be fun, and you need to have these multiple inputs. So for example, a person's trying to balance on this ball, and they might be throwing and catching another ball with their arms, and they might be doing a cognitive strategy at the same time. For example, naming fruits that begin with the letter A, that sort of stuff. So those kind of things, when the brain's got to be really, really busy and use all those different pathways, that's when we start to get improved movement. If they were just focusing on balancing on the board, they'd find it a lot harder to do than when they're doing the multiple activities. When people are engaging in tasks, you want to make the engagement be meaningful to the person. So if the person likes sporting activities or like netball or likes dancing, you'd want to use those activities that they enjoy as part of their therapeutic physical rehabilitation. The distractions can be, listening to music and singing. So we've had some people that love singing. So incorporating singing into their therapeutic rehabilitation is really important. For other people, they might hate singing, but they might like listening to music. So anything that's meaningful to the person is really important. Focusing on the destination, for example, if someone has to walk from A to B, instead of focusing on each step, trying to focus on, I'm trying to get over there, I'm going to take this plate over to that table. So you're focusing on the destination rather than focusing on trying to lift up each foot to get to the table. So a lot of this is video. This is an example around how the redirection of attention works. So we've got a lady here that's got really poor gait, poor balance, difficult for her to move and put one foot in front of the other. So really quite unstable on her feet. So now she's going to be focused on trying to carry this ball thing on her head. So her movements have become much smoother and much more automatic. So that's part of demonstrating that normal movement can occur with FND. So you want to be trying to harness these kinds of activities as part of your therapeutic rehabilitation. And then now you can see that she's not focused on that thing on her head and her balance and stability has gone off. This is a case study of Caitlin. She wanted to have her real name used and she wanted her story shared. So this little girl lives with her family, so sort of stable family upbringing, mum, dad, sister, lives in Albury, New South Wales border. She had some learning difficulties, but she was a happy and healthy child. In 2018, she experienced some back pain and spasms. She had an appointment booked, but developed FND in July 2019. So just after her 11th birthday, she became locked, dystonia. Her shoulders became locked in this position for quite a long time. She was accused of faking symptoms by her local hospital. She was seen at a children's hospital and no explanation of the diagnosis was provided, but the mother found the functional neurological disorder written in her child's discharge notes after she left the hospital. When they saw CAMS, they said, oh, she's got FND because she had an episode of school teasing 3 years prior. The mum didn't relate to that explanation because she said, that was 3 years ago, nothing's come up since that time. All right, come on. So this is in the early stages when she's sort of locked in this dystonic position. And she's become quite weak in terms of using her hands. It then progressed and she had trouble walking. She had trouble standing up, holding her weight.
Right, get underneath her. Caitlin, try and straighten up. Straighten up. Stand up. Stand up. All right, come on.
She would often have these drop attacks and she'd collapse to the ground. She would sometimes get warning and she would place herself on the ground before she collapsed to the ground. And, her eyes are closed. And you might have noticed in the video, her eyes was closed. And again, her eyes are closed here. She's just not able to open her eyes.
Can you open your eyes? And scrunched.
Yeah.
Can you put your lips together? Can you smile? Yeah. Can you raise your eyebrows? Can you open your eyes a little bit?
So here she'd collapse on the floor and now trying to use distraction.
Now move your toes. Move your other hand. That's it. Do you think you could try and sit up? Yeah, try and sit up. Now, can you move your toes? Move your leg. Keep reading it. Keep showing you. Keep reading it. You're doing really well. Tell her what she should do next, Coop.
You should try to do it. You notice it? That's it.
And they're getting her to focus on the toy as part of that distraction. Other type of techniques that can be used is like reading backwards, counting backwards, and other types of sensory inputs. So Caitlin deteriorated quite quickly. She began to experience hallucinations, dissociation, and she regressed to this childlike state. She started crawling, she started using baby language. The specialist said that this was her brain's way of shutting off and protecting her from what was going on. They tried to get her into a locked mental health unit, but it was not equipped to handle her physical symptoms and where she was at. So the family decided against psychiatric admission and they tried to manage her in the home environment.
Blue stuff in the sky. I got it. That's it.
What do you mean? How many is there?
8. And I got cats and all.
There's nothing in the sky. It's just in your room. Where are you?
In my room. Like, is this my room?
Yes, this is your room. What's your name?
I found
What are you doing?
all the stuff.
Do you think you can go to sleep? Why not?
My brain says I can't sleep.
Why is that?
I don't know. My brain tells me.
And a number of children, it has been mentioned, a number of children have had hallucinations alongside FND. So the mother, she had a lot of time off school, she had the rest of the year off school. The mother, they didn't have access where they lived, they didn't have access to treatment where they lived, so they didn't have access to physio. So the mum basically did her own rehab. So she was using one of those chairs on wheels and practicing her walking, going up and down the hallway. When she became paralysed, her mum, let her know that she was there, stroked her, didn't make a big deal out of it. Up to vitamins, so B12, magnesium and fish oil. They did gentle yoga, and yoga is often, a lot of people will find benefit from gentle yoga. They did some brain training with eye movements. They had a physio ball at home and did a lot of exercises on the physio ball. And they tried to avoid using aids. So they had a shower aid in the shower, and they used a wheelchair when they went out. But in the home environment, they didn't use disability aids. So by February, she was doing a lot better. She returned to school. And has basically remained symptom-free. She does have a lot of back issues, ongoing back issues, and she really can't remember what happened in that last 6 months of 2019. And we sort of think that might have been, the brain's way of sort of protecting her. This is another little girl about her story.
I was walking down the stairs at my school and I just skipped a step to get past some people, and I hurt my back quite a bit actually. It didn't hurt as much when I first did it, and then it got harder to walk.
Well, Jessie called from school and she had hurt her back, and so she wanted to come home.
So when we all got home from work that day, we ended up going to Instacare, and the doctor saw her there, took some x-rays, and they didn't really see anything in the x-rays that was a concern.
I went home and it just kind of got worse and worse. My back started to hurt more and there was shooting pain going down my legs.
So the next morning I went into Intermountain Pediatrics to try and see if we could figure out what was happening. We saw Dr. Clark and he ordered an emergent MRI, and they couldn't see anything on the MRI that would cause her pain.
I think gave us some steroids and some painkillers and sent us home hoping that the pain would go away.
Within the next day or so, I had lost all movement and feeling in my legs.
And so I called the next morning to talk to pediatrics to see if I could get Dr. Clark to give us some more about what it is that we needed to do. And he called me back and said, you need to take her down to Primary Children's.
And then we stayed there for 4 days, just trying to figure out what was going on, doing tests. And by the end of it, they had diagnosed me with conversion disorder.
I called Peds Rehab, got her an appointment. I knew that they were going to be the best ones to really help get her strength back and her motor skills back. So I called him a number of times to try and get her appointment moved up and see what we could do to get her in sooner. And he would call me back and he made sure that I was comfortable. He gave me some exercises to try with her at home. He did some research. He called me again. He said, I want you to try this. I want you to do this. So he had a really good idea of how she was doing before he even saw her as a patient.
We started to see Sean at Peds Rehab, and he was helping me through it.
Having her in physical therapy, that first day, the first time we went, she was in pain. It was hard. He moved her and did all the painful things that sometimes happen in physical therapy, but he was able to really push past whatever was blocking her and just get her back to where, hey, I have legs, they work, they do things.
All of the exercises we were doing just felt like games, and it was really fun for me, actually. By this time, I could walk, sort of. Yeah, I was kind of zombie walking.
I mean, one of the neat things was when she started walking again, I just said, hey, okay, Jessie, since you're standing, you need to come chop onions. And she hobbled right over and started cutting onions.
She loves to cook. She loves to ask for advice on cooking. We do a lot of cooking together.
I think when I went back to Peds Rehab and Sean was telling me about how much I had progressed from doing the home exercises, it helped to know that my progression was being noticed and that it really was making a difference. Yeah, we were just doing physical therapy and it was getting better, but I was still walking like a zombie. And then I went on a trip to Jackson Hole with my dad. I think the last night we were there, I started to be able to walk normally. Within a couple of days, I was able to run. And then a couple days after that, I could jump. If you go to Peds Rehab, there's really nothing to be scared about because they're gonna help you through it. And it's really just gonna feel like a ton of games that you're playing. But in the long run, it's gonna help your recovery so much.
So it's really important that the children are given the opportunity to participate in programs like that. And while they're going through the rehab, it'll be very difficult for them to continue in the school environment and doing exams, assignments, that sort of stuff. So there may need to be modifications to what's happening at school while they're engaging in a rehabilitation program. This is another girl, a bit older. So she also collapsed at school and she went into complete paralysis and she could just wiggle a couple of fingers and toes, also in extreme pain. And she said initially the only muscle that doesn't hurt is her tongue. She was 15 and a half and she was in hospital for a month. So here her body's completely shut down. And she can't move, can't open her eyes. Here they're trying to get some movement in her.
Yeah, all right, ready? I'm going to start when you start. Keep going.
So they're trying to get her to count backwards while she's doing the movement.
Catherine, it's Mary.
Yep.
I was just wondering, is there a particular socioeconomic group as well, or that we're seeing this occur in?
Not necessarily. Some of the research suggests maybe slightly lower, but I'm not so sure. I think it really can hit anyone.
Mm-hmm.
You know, we've had, you know, sort of high flying executives, you know, athletes, dancers, you know, people with very poor literacy.
Mm-hmm.
So it can really affect anyone.
Okay.
Yeah.
I was just curious because as I was sitting here and seeing most of, and it's possibly because obviously most of the people who've agreed to give their content are young females. And I was just starting to think as I was sitting here watching it, is there a certain cohort that we're seeing?
So definitely
female.
more. Yeah, so definitely more females, except if you're below 10 or over 65. So definitely more females, but males still get it. So that's more the common thing is females, and really it's often either your high achievers, so people who really push themselves, or it'll be people with complex comorbidities. So you know, you might have someone, you know, they're sort of got a lot of trauma, a lot of abuse. They might have family members who are unwell, you know, neglect, that sort of stuff. So people who their body has been exposed to a lot of stressors, whether it's sort of physical stressors, mental stressors, or stressors that they've put on themselves because they've been high achievers and they've worked too hard. They might have, you know, for adults, you know, carer burden where they're trying to look after a whole lot of sick children. Domestic violence is also another one that's come up, both for children and for females, and also for men who've been in domestic violence relationships and I've had men who are homeless as well. So, you know, it can really hit anyone. But really, it's sort of, you'll find that people tend to have a lot of other stressors going on.
Are people in that lower socioeconomic group disadvantaged because of access to
Yep.
treatments, etc.?
Absolutely. Yeah. So that's sort of where you see, you know, potentially people who have that money behind them, they can afford to pay for the top specialists. So it's a very expensive illness, you know, to see a neurologist, you know, $550 straight up. Likewise for any of your sort of private doctors, if you're waiting to see a public doctor, you know, you might wait 8 months for an appointment or longer, because you're waiting for a public doctor, whereas a private doctor you'll get in straight away. You know, people who can afford, you know, private physio, private speech, private occupational therapy, private psychology, obviously they're more likely to have better outcomes than someone that can't afford it.
But it's not, this is Helen, it's not even waiting to get in. What if they get in and it's not a physio or a neurologist or whoever who's really up on this?
Yeah, exactly. And that happens as well. You know, people have paid a lot of money and not got the right outcomes. You know, often they'll be sent to a psychologist. Psychologists never heard of it. They need the specialized physio. So if you see a physio that doesn't actually understand FND and they go, okay, well, it's presenting as a stroke, so we'll treat it as a stroke, well, then they can actually have worse outcomes because you'd be focused on, you know, the little movements, whereas with FND, you want to distract from the movement. So you're then given the wrong treatment, which can make the symptoms worse. So not having access to the right treatment is a real problem. Yeah.
This is Helen again, this is a little bit left of centre, but I'm wondering if some of those things like giggle incontinence, because that's definitely the pathway where and it's very common with young adolescent girls, they giggle and then they lose their bladder. I'm wondering if that could be FND rather than other things. Has that ever cropped up?
The incontinence issue is a problem. A lot of people, and people don't like to talk about it, but a lot of people are having incontinence issues. I haven't heard of it with the giggle, but definitely incontinence is a problem with this condition, and it's really distressing, especially for young people, you know. Yeah. Yeah. Were there any other questions at that point? Okay. By this stage, she's up and standing, and she's shifting weight and trying to work out basically how to lift up her leg and put one foot in front of the other. So even just trying to stand can be a lot for a person with FND, trying to stand and balance before they even work out how to put one foot in front of the other. Now they've got her walking with equipment.
So good, Bryce.
Yeah, it is.
She's getting her walking back.
But have to sit in the eggshells.
So she's focused on the destination to get to the eggshell.
Yeah. Picking up the pace.
And a little while later.
Woo! Look at that.
So for her, within a month, she's gone from being completely bedbound and she's now ready to go home.
She wants to pack up all her clothes so that she's ready to go. Because what did the doctor just say?
Amy said, yes, I can possibly go home tomorrow or Thursday.
So she did really well. She went back to school. She did have a relapse. So when she got sick, so that was what triggered her relapse, and she had another 10 days in hospital, but she went through the same process and was able to relearn how to walk again. She then had a couple more episodes. For her, she was an athlete, so running and illness combined seems to trigger her. So when she's been sick and she's pushing her body, she didn't end up doing the full sort of HSC because of the exams, but she was doing a course to get her into uni anyway. And then she had to just manage. So she was at school full time, but she went to the office for a nap. So to kind of manage her fatigue in the school environment. She had a lot of time off school, but she was still doing really well. So she was one of those sort of high achievers, but she couldn't manage the sort of stress of all the exams and trying to get an ATAR. So for her, it was looking at pathways into uni without doing the full HSC. So in terms of occupational therapy, it can be quite important to involve an occupational therapist in a person to help them do activities that are meaningful to them and important, and to look at how to participate in daily activities, how to determine their care needs. So if a person has an OT, they might be involved in supporting the person in the school environment, looking at what does that person need to be able to manage in that school environment, how does she manage those triggers in the school environment, and look at graded return to school, looking at accommodations in the school environment to manage what's going on, and looking how to manage pain and fatigue as well. A number of people present with sensory issues, and as an OT we do a sensory profile, and some sensory can be a trigger and some sensory inputs can be a calming input. So we do this profile and we sort of look at what is triggering these person's symptoms and what sensory inputs can be effectively calming for the person. So hypersensitivity, so that can be if they've got hypersensitivity to noise, like if someone drops something on the ground and it's got one of those vinyl floors that are quite noisy, that could trigger a seizure for someone. Some people are photophobia, so they're sensitive to light, so they might turn up to school with sunglasses on. People who have the sound issues, they can wear noise cancelling headphones, earplugs, to try and help manage the sensory input and the sensory overload. as I mentioned, some people are going to need equipment. It may be a temporary item, or it may be something that they need ongoing. There are children who have ended up in a wheelchair and they're just not able to walk. Whereas with other children, for example, in those situations, you wouldn't want to have left those children in a wheelchair because they were able to make great gains. So you want to get people into rehab, able to have that really concentrated time in rehab so that they don't need these equipments. But for some people, especially older people with complex comorbidities, they may end up in a wheelchair ongoing. And for other people, it may be they need a wheelchair for a short period of time and then they don't need it. So they only use it when they actually need it. And, all equipment can result in sort of secondary complications. Use of crutches, uses of walking sticks can cause pain. You can get secondary complications, and it can make the automatic movements less automatic. So seizures are often one of the main problems that people face in the school environment, which schools are often, concerned about. It can be quite triggering for people around them. It can look, really quite distressing to witness. So we often do like a seizure management plan and work with the person, work with the school, work with the family who have witnessed seizures, looking at things, what happens to a person before a seizure? What are the warning signs that they might be having a seizure? What are the potential triggers? What are the potential patterns? I had one person that told me, I always seem to have a seizure at this time in the morning and this time in the afternoon, but not at this time for the rest of the day. So trying to work out, well, what's going on for you at those times? Is it medication that you're taking? Is it stressors that you're dealing with? Trying to understand what are the patterns around these seizures and what are these triggers? Warning signs are really important, because if you get a warning sign before the trigger, you can start to introduce strategies to try and sort of reduce the seizure, prevent the seizure, and things like grounding techniques, helping people, get to a quiet place, surrounded by cushions, feeling safe, feeling supported, redirecting the attention. All those sort of distraction and grounding techniques can be really, really important. For some people, they might have an animal that lies on them. So a lot of people will say, oh, my dog knows when I'm about to have a seizure and my dog will come and lie on me. They will warn me that I'm about to have a seizure, and the dog will lie on me and help to ground me and provide that soothing for me, and it will help me to come out of my seizure. Some people do have seizure assistance dogs. Some dogs will just automatically train themselves. They know, I go and get a carer when this person's about to have a seizure. The carer comes back, the dog then supports the person who's having the seizure. And for other people, putting ice on a person, I wouldn't like that, but if that works for the person, putting ice on their skin. Someone put a strongly flavored, I think it was lemon juice or something, in a person's mouth, so they got that sort of taste sensation. So it can be trial and error, and some things, a person might say, oh, that makes me worse. Another person might say, oh, that makes me better. So it's finding what is going to work for that person in that moment in time. But for a lot of people, especially in the school environment, if they're aware that they're about to have a seizure, taking them somewhere quiet, away from other students, getting them to that sort of feel safe and supported. I can go into this little thing there, there's bean bags, I can lie on the ground, I'm going to be safe. And just helping that person feel safe and calm is really important. I do have a seizure management plan, and I'll send you a copy of this as part of the resources. This seizure management plan is useful, one, to sort of people to understand, what does my seizure look like? So when it presents, so for a teacher that might be new to this child, okay, this is what is happening to this child, and it looks like the child is about to have a seizure. Understanding what a typical seizure might be. So for some people, they might have those hyperkinetic movements, look like a tonic-clonic seizure. For some people, it might be more like an absent seizure, a drop attack. So people might be just not present. People might just fall to the ground and sort of, someone says, they look like they're just sleeping on the ground. Some people do stop breathing. I have one client where she sort of holds her breath and people get worried, do I start CPR because she's holding her breath? So understanding, how do the seizures normally present for this person? What is a normal duration for this person? If it's an epileptic seizure, if it goes for longer than 5 minutes, you quickly call an ambulance. Whereas for someone with FND, I had a client and said my seizure went for 38 hours. So they can last a lot longer than what you might see for a person with epilepsy. And understanding, what is the frequency of seizures? So is it sort of, once every 2 weeks? Is it every single day? Is it multiple times a day? So you need to understand the duration and the frequency of seizures in order to manage it in the school environment. And then finding out from the person, what do you want people to do? If you're having the seizure, what is helpful for you, but also what is not helpful? Because someone said, oh, they put ice on my leg and that draws me out. Well, that might be unhelpful to someone else. So finding out, what do I want you to do and what do I not want you to do? And then what do I need after a seizure? Am I going to be able to get back up and participate in the school activity, in the school lesson? Or am I going to need to lie there for 3 hours to sort of rest and calm out of that seizure? And for some people, they say, I might have a seizure and then I might get paralyzed. And then, I might need to be in hospital because I'm paralyzed. I might need to have a catheter. So finding out what happens after the seizure is really important. I had one client the other day, she had a seizure and within 3 minutes of the consultation, she was out of it for a few minutes. And then she came back and just finished the meeting. So she was able to get back straight into what she was doing as she was prior to the seizure. But other people may need to rest and remain quiet for a period of time. And then understanding when you call an ambulance. So if you've got someone, that's feeling really worried, you might want to call an ambulance, but the person may not need an ambulance, and you don't need to jump to an ambulance every time a person has a seizure. So if the person's had a fall and they're injured, they're bleeding, they've broken a bone, obviously you need to get medical attention. If the seizure is a typical seizure, it's what you've got on the seizure management plan, it looks like a normal seizure, you have already agreed with the parents what you're going to do, you just follow the seizure management plan. You might keep the child quiet for a period of time, you might call the parents, or the child might be able to go back to school. So finding out, when do we call an ambulance? And if you're concerned, if the child, had someone saying, we didn't know whether we had to do CPR or not. So if you're that worried and the person's not breathing, well, you might want to call an ambulance. So it's having this seizure management plan where you're on board with the child, the family, and potentially like the specialist, the medical practitioner. Were there any questions around the seizure management plan? Yep.
Yeah, Kate, it's Mary again, and this may be a controversial question,
Yep.
but just given the fact that seizures are diagnosed as a sudden burst of electrical activity in the brain normally,
Yep.
and clearly with all of the evidence and the studies that have happened, that's not occurring in
Yep,
these
that's right.
individuals. Is it appropriate to call it a seizure?
So they are. So the functional seizures, there's been a lot of discussion around that. Some people are calling them non-epileptic seizures. Some people call them dissociative seizures. In the UK, they were calling it attacks. So what they're currently calling them are functional seizures. In the UK, it was non-epileptic attack disorder. They were then dissociative attacks. You then had your psychogenic seizure. So there's a million different names applied to the same thing. But yeah, they are often called seizures. The attack word is not used a lot, and people didn't like attack because then it sounded a bit like a heart attack. So other than attack,
episodes is what we've heard more than anything else, functional episodes or dissociative episodes.
Yeah, that doesn't distinguish it between, like with an episode, it could be like an episode of paralysis. It could be an episode where I've got a flare up of my motor problems. So it's understanding what type of symptom that we're dealing with. So the episode things because people use the word episode, oh, I've had an episode, and that could be, oh, I can't walk today.
Yeah.
So it's really finding out from the person what they're using, what term they're using. And I tend to use, if they call it a dissociative attack, then I use that terminology. If they call it non-epileptic seizures, you know, I wrote down in someone, you know, dissociative seizure, and they change it to non-epileptic seizure. So it's using the term that they're comfortable with, but making sure that everyone's on the same page around what are we actually referring to.
I think where the complexity lies, and I like the terminology functional seizures, and I'd like to see on the seizure management plan it stretched out a bit further to be called my functional seizure management plan, because in the instance where we have students who do have epilepsy and do have functional seizures, that's when it becomes very complex for teachers and teacher aides in schools.
Yeah, it is. And because you have, and it sounds like what you're saying, you've got people with epilepsy and they've got functional seizures, and knowing what is what, and that is when it is really complex. And in that case, I would be more cautious, because it can be very hard for a person to distinguish, are we dealing with epilepsy? Are we dealing with functional seizures? And even parents will say, I'm not sure which one's which. You know, people do struggle. So it's definitely a lot more complex when you're dealing with epilepsy and functional seizures. Yeah. So if you know that you've got both, you'd want to also have your epilepsy management plan as well. And you probably want to combine the two, and you'd probably have a slightly different management plan if you've got both epilepsy and functional seizures.
Yeah, well, they'll be completely different plans of approach for those students if they're having.
If it's an epileptic seizure, you know, medication's appropriate. If it's a functional seizure, the medication probably won't work. So it's definitely a lot more complex in those situations.
Which is why I kind of think it'd be nice to see them far more defined as to functional seizures or...
Well, this can be modified. I mean, I've got functional seizures on the first page, but I can, for people with functional seizures, a functional seizure management plan. So that can certainly be edited to make it, and I can edit it and send it to you with a functional seizures on here. Yeah, which is probably a good idea. Yeah, but definitely a lot more challenging if you're dealing with both. And the outcomes are often a lot worse if you're dealing with both. So in terms of functional seizures, what people have said has been helpful is, you know, having the people around them being calm. So talking to me is really helpful. Talking to me can help me bring me out of a seizure. If people are getting, you know, people around them are anxious, as they're over concerned, it can help to activate them, and it doesn't help the seizure. So they need people to remain patient and calm, keep chatting, but not expecting me to respond, because people can't respond. This was referring to practitioners really in relation to nurses. You know, it helps when they're being kind and respectful, you know, staying calm, speak kindly, reassure me, know that I can hear every word you say. And someone said, you know, a nurse simply held my hand and said, I'm here for you. And just sitting there holding her hand was what she needed at that point in time. So recognize that, you know, seizures are serious. People do get injured, and people have died during these functional seizures. They are real, and they are very disabling. It doesn't just go away if people accept the diagnosis. And functional seizures, obviously, you need to treat them, but the treatment is completely different to epileptic seizures. That one. These were just examples of distractions that people have used. It was accounting backwards, and then considering the child's sort of academic level. You know, if it was a Year 2 student, you wouldn't get them to count back by sevens, but if it was a high school student, you pick a level of cognitive challenge that's appropriate to that person. Likewise with alphabetical challenges, mind games, sensory input. Counselling can be really important, as I mentioned before, helping people to get in touch with their emotions, because a lot of people are rather disconnected from their emotions. So people who've pushed their body, they've gone through lots of trauma, but they say, you know, I've coped really, really well with this. I've been through A, B, and C. All this stuff happened in my life and I've got on with it, but they haven't really dealt with it. So they've cognitively got on with things, but their body has come up and sort of started to collapse under the weight of it. So in terms of counselling, it's helping people to understand their warning signs. It's helping people with their grounding, with their attention refocusing, distraction, relaxation, addressing self-esteem, mood, anxiety, and trauma. So self-esteem can get a great big hit in terms of FND. As people lose confidence, they lose their abilities, and they can get quite distressed. And obviously we want people to be treating your comorbid psychiatric conditions as well, because this can help with their FND as well. There's no FND specific psychiatric medication, but if a person has other psychiatric illnesses, they can get relief through various psychiatric medications. For example, if they have bipolar, if you treat the bipolar, it can help with their FND symptoms. Some people are on medication which assists in managing their pain. Some people are on mood stabilizers, for example, Epilin, and that can help with their seizures. And there are people also on medicinal trials using CBD, and they are finding that helpful for their seizures. Of course, the psychotropic medication has sedating side effects, and that can be problematic in the school environment, getting to school in the morning, being sedated and sleeping in class. So this is, if someone comes up with FND, if you've got a new symptom, if your symptoms are changing, people are like, what do I do? So, you'd start with all your sort of deep breathing, all your sort of self-management skills. Is your breathing, if your meditation, your distraction, getting some rest, is that helping? If it is, that's okay. If it's not, and your symptoms are ongoing, you do need to get medical treatment or medical care. So if people are in danger, if they're at risk of medical complications, if they can't swallow, so not being able to swallow water and food is obviously a major issue when it's ongoing. And we've had people, not able to consume water for a week or so, and they get really ill. Which then exacerbates their symptoms. If they can't breathe, they can't toilet and shower, it's under these circumstances that they need to go to hospital. And if you're worried, you're always better off just to get a medical review if the symptoms are not getting under control. I've covered that. Pacing is really important. A lot of people will start to get better and then they go, oh yeah, I'm recovering, and they quickly get back into their normal day life, and they'll start to take on too much, and then they'll have relapse, and then they'll get depressed because they had a relapse. So that sort of graded exposure, if a person's had a month in hospital, you'd want to slowly reintroduce them into the school environment. So not going back to the full school workload and all their extracurricular activities straight away, because people do have remissions. And we see a lot, people are like, oh, wow, my legs are working again. I'm going to go for a 10-kilometer run. And then the next day they're paralyzed. So really pacing is really important, or you end up with these boom bust cycles, which effectively people end up getting worse over time. Some people sort of use the spoon theory. So, if I've got so much energy per day, what am I going to do in my day that's meaningful for me, things that I have to do, things that I need to do, things that I want to do. And for some people, just getting out of bed and taking a shower can use up a lot of their energy. So how are they going to manage their energy during the day? And this is one of the big things, physically getting to school can be a challenge for some people, and then they don't have the energy to participate in the school environment. In terms of the autonomic nervous system, what we're sort of seeing here is a lot of people, when they are in that sort of paralyzed state, something's triggered them and the body's gone into this sort of life threat shutdown mode. So things like shame, feeling hopeless, feeling depressed, the nervous system goes into that freeze response. When they're stressed, you've got your sort of hyper arousal. And what we want to do is to keep people feeling safe, feeling calm, feeling sort of socially engaged, not under threat, so that their nervous system can function normally. The research has shown that in people's nervous system with FND or conversion disorder, is that they have an increased heart rate and they have a decreased heart rate variability. So this means they've got reduced resilience, and it's showing that, you know, their greater heart rate means that their body has, you know, the increased autonomic sympathetic kind of stress on their body. So we're seeing the sort of hyperarousal. We have this dysfunction in the threat response. So sort of mild threats that people could deal with can trigger, you know, a whole body shutdown. And things like your amygdala, your threat response. So, you know, if a teacher might be triggering to you, your whole body can shut down if you happen to see that teacher. So things like that can trigger an FND episode. So what we have here is a lot of people, their nervous system is jumping into this freeze response. So they're feeling dissociated, they're feeling numb, their body's shutting down. And this is an increase in autonomic arousal. So it sort of goes past your fight, flight, sympathetic system. And what we're all the time wanting to do is to help people ground, bring them back into this ventral vagal nervous system. So your social engagement, helping people feel connected, helping people feel safe, helping to orient them to the environment, doing your mindfulness, doing your grounding, being in the present moment and reducing that threat response. Things that can help activate this safety response. So feeling safe, feeling connected, being positive. If people are always depressed and only focus on the negative things around what they can't do, that's going to sort of reduce their resilience. Feeling heard and feeling validated is really important. So acknowledging what people are going through, that feeling of being heard is really important. So it doesn't have to be a real life and death threat. It's just the nervous system has that activated response, and the nervous system will respond exactly the same way as if they're in a real life and death situation. So you want people to feel calm, to feel connected, to feel grounded, so that real sort of moving, soothing kind of feeling. So some people do have assistance dogs, and they're starting to be used a bit more commonly. So used in seizures or functional seizures, but also for people with FND. So they can be helpful in terms of trying to regulate the nervous system. It can help to provide that feeling of connection. So if people have had a trauma response, having an assistance dog that they can connect to, feel calm, feel safe with, can be really important. An assistance dog can distract people from the distressing symptoms. It can provide sensory input, so that sensory touch of an assistance dog. People say that their dogs can detect a seizure episode coming on. It can help to bring people out of a seizure episode. It can support mobility, so sort of providing that bracing against people's legs, reducing dissociation, helping people ground and self-soothe, and also physically keeping people safe from injury and alerting caregivers in the event of an episode. So examples of techniques. So the breathing's really important. A lot of people will say that they hold their breath. So helping people, you know, breathe in, breathe out, breathe in, breathe out can be really important. So focusing on the breath can be used to help regulate the nervous system. You know, the mindfulness, you know, what can you see? What can you hear? Can you hear the birds? Can you hear this in the background? What can you smell? So all these sort of using your senses can be really important to ground people, to help reduce the attention to the symptoms. So in terms of in the school, I'll send you the video. So how do we manage these episodes in school? There's a 40-minute video that I'm going to send you. But obviously, you know, if someone's in a wheelchair, you'll be dealing with, you know, as you would with anyone, spinal cord injury, etc. You'll be dealing with disability barriers. You might be dealing with people that have periodic limb weakness, periodic gait disorder, people that can't move, they can't relocate between classes because their movement has gone. They might be unable to do stairs. Jerk, so abnormal movement. So some people, their limbs will just abnormally move. I had one girl that says, you know, my limbs just move and start hitting me in the face, or my arms are moving wildly, and they could accidentally hit another child. Dystonia, especially if they've got dystonia in their hands, it makes it really hard for people to write, also very painful. And if people can't talk or they can't swallow, again, that's problematic, especially, you know, in the school environment. If they're not able to talk, they can't interact with other students, can't participate in some school lessons, etc. Being aware that, you know, some of their symptoms may be invisible, you may not be able to see all of their symptoms, so things like their chronic pain, their chronic fatigue, the photophobia. So are they having problems with the light? Do they need to wear glasses? Do they need to wear noise cancelling headphones to school? So we do need to make accommodations for students in the school environment. So Disability Discrimination Act, you know, promotes inclusion within schools and in other education settings. So this is the video, which is 40 minutes. So what I'm going to do is I'm going to send you the link because we've nearly run out of time. And this is around how do we, and it goes through an example of, this is, you know, a child, these are the symptoms that we were dealing with. We had these symptoms that were consistent all the time, and we had these episodic symptoms. So how do we deal with these episodic symptoms in the school environment? So I'll send you the link to that video and you can watch it in your own time. Being aware, so getting to the end of it now, but, you know, treating people with compassion, understanding that, you know, the child, the family are under significant distress. Supporting other students to understand the condition is really important, so that the students, like the teasing, the bullying, that can be a real problem. You know, disability bullying is a real problem when students are being accused of faking symptoms because one day they can walk, the next day they can't. That's really distressing for a person. So trying to help the other students understand what's going on with this person, understanding.
Are there any resources, any posters, resources about that with your organisation?
For other students, it's probably something that we need to do. Nothing specifically for the school environment, but maybe that's something that we should be doing. So I'll keep that on my radar.
Just a suggestion, but
yeah,
good.
Yeah. But understanding that the symptoms, you know, sort of by definition with FND, the symptoms fluctuate and change over time. And supporting people to engage with their treatment team. So allowing time off for appointments, allowing people time off to engage in that intensive rehabilitation program is really important. Lack of understanding will obviously increase a sense of isolation. So helping the family, helping the child feel included is really important. And, you know, when a person loses the ability to study, it does have an impact on their life. You know, the socialization aspect of school is really important, their friendships. So it's really, I mean, FND, people say it's a lonely and isolating illness, and it is. So trying to help that child be included in the school environment as much as possible within their limitations without putting too much on them is really important. So, and that will change over time. So that sort of management plan will change over time. So, you know, if they get sick, if they get flu, things will completely change. They'll have periods where their symptoms are worse, periods when their symptoms are better. They'll probably do worse around exam time because that's when there's a lot of stressors. And especially things like the HSC, that's really, really problematic. And when people have cognitive issues, it's in the video that the father says, you know, my child had this memory problem, and if she slept for longer than 2 hours, she would forget what she learned. So she's trying to do the HSC and she's trying to study and she's trying to learn stuff, but when she sleeps, she would lose all her memory. And we had other people that said that, you know, they woke up and they'd lost, you know, so many years, you know, amnesia. They would lose, they wouldn't recognize their parents, they wouldn't recognize their family, they wouldn't recognize their friends. So those cognitive issues obviously really challenging in the school environment. So people said, you know, things that they needed to hear, you know, I'm here, going to help you, I'm listening, I believe you. This is real. You know, I can imagine how scary this is for you. So letting that person feel heard is really important. Working with the family, so the parents are going to know their child's best. They will be able to tell you, you know, what works well, what doesn't work well, you know, validate their concerns. The family will be under a lot of stress. Yeah, if you haven't already seen it, neurosymptoms, there's a lot of resources under neurosymptoms. It has a whole lot of information around each of the symptoms. So if you've got a child with a particular symptom, you can have a look at this website. There are a few resources. Yeah. So are there any questions?
No, I think that was great. Thank you, Kate. Much appreciated.
Okay. Right.
Sorry, I've kept my camera off most of the time because I'm on low
right.
bandwidth here today. So
Okay.
Yeah, I'd agree with Mary. There was so much in that you know, really just increased our knowledge of it. It was really, really good. I could keep listening for longer. Yeah.
Okay, well, I'll send you the video.
I
So
agree. Yeah.
I think it starts at 53 minutes, which is all that stuff about the school. The stuff before that is probably repetition of this. So I'll send you that video, and then what I'm going to do is splice these slides into smaller units, and then I'll email them. Who's the best person to email it to?
I was wondering, maybe would you like it to you, Mary, because you are the coordinator of this? Otherwise, the North Queensland team were the ones that started this off, and you've already got their contact details, so it doesn't really matter either way. Is it Talia? Have you got were you the contact?
Talia's details. Yeah.
Yeah.
Yeah, it doesn't matter who you send it to, we'll share it.
You all get it. Yep.
Okay.
Either or.
Yep.
Yeah.
So I'll send the slides. I'll update the seizure management plan to keep it more specific around functional seizures. So then I'll send you that and a couple of other flyers as well.
Fantastic. Thank you, Catherine. Yeah.
Cool.
Yeah, thanks.
All righty. Okay. Well, I should get that to you hopefully by the end of the day, if not today, tomorrow.
Mhm.
Okay.
Brilliant.
Thank you.
Thanks
Very much. That was great.
Cool.
Thanks.
Thank you.
Bye.
Bye.
Thank you.
Bye.